Good afternoon, everyone. Welcome to this month's session of our Ask the Expert series. Today, we are going to be joined by two of our law enforcement mental health learning sites, Madison, Wisconsin, and Denver, Colorado. We have some people still joining us, so I'm going to give it probably another minute or two before we really get into the content of today's session. I will remind you all that today is going to be recorded. We are currently recording, so this will be available after the fact. If you have to step away before the session ends, or if you want to share this with anybody that you work with, feel free to do so. You can find the uploaded recordings on the event series page, which I'm putting into the chat right now. Right. Okay, folks, we're at 2:02 Eastern. I'm going to give us just another minute or two to let people finish filing in. I am going to mention to everyone, not only are we being recorded today, but our Ask the Expert series are a little bit more conversational, a little bit more back and forth, a little bit less formal. So I do encourage everyone who is comfortable to put themselves on camera so that you can see and be seen by our presenters today. We have a great group who are going to share their expertise with you. And it always helps to get the conversation going if we can see one another. So I encourage you all to jump on camera if you are able. If you have questions, we're going to start with some opening introductions of these two programs that we have joining us today. But if you have questions at any point, feel free to throw them in the chat. Or once we get to our question and answer portion of today, feel free to take yourself off mute, use the raise hand function, and just ask a question. We are not looking to be super formal today. What we want is a back and forth. We want to give you all the opportunity to ask these folks whatever questions you may have about the work that they're doing and how you can possibly emulate that work. So it looks like our entries are slowing down. And so once more, for those who are just joining and getting connected, I'm going to remind you that we are recording today's session. The recording will be posted on the website that I put in today's chat, our Ask the Expert series event page. Those of you who are comfortable and who are able, please do put yourself on camera. It helps create that atmosphere of back and forth conversation, which we're hoping to get a lot of today. So without further ado, people are still joining, but I'll let them in. And I want to get to our experts today. So for those of you who are just joining or have been on for a minute or two, my name is Ethan Aronson. I'm a senior policy analyst at the Council of State Governments Justice Center. I work on the law enforcement team, which is within our behavioral health division. I do primarily technical assistance work for JMHCP Connect and Protect grantees around the country. I'm also the point of contact for our law enforcement mental health learning site program, which I am very pleased today to bring you some representatives of our program to talk with you about their crisis systems and how community response as a new team fits into that kind of crisis ecosystem and crisis spectrum. So if you have any technical questions, technical issues, you can route them to me. My colleague, Joseph Arnett, is also here. So if you do run into an issue, you can chat him as well. We're here to help out and to move or to help facilitate the conversation. So this work is possible with the support of the Bureau of Justice Assistance. They provide a lot of funding and institutional support for CSG's work in the field. This series was one of our larger pushes for this year of really just trying to connect folks with the peer learning sites that we have and allowing them to deliver some of the excellent information that they have at their fingertips to you all. So you all don't probably want to hear too much from me because we have the experts on the line. So I'm going to do some quick introductions for you and then pass it over to our presenters for today. So from the Madison, Wisconsin learning site, we have Sergeant Jared Prado, along with Hope Edgren, who's a law enforcement crisis worker, and Eric Kinderman, who is a crisis responder with the community response team called CARES. From Denver, Colorado, we are lucky to have Chris Richardson, the Director of Crisis Services at DPD, and Tandis Hashemi, who is the operations manager for the STAR program, which is the community response program in Denver. So I'm going to turn it over to Sergeant Prado and the Madison folks to give a brief overview of what they do, how CARES fits into this crisis ecosystem. And then following that, we're going to have Denver do the same thing. After our quick overviews, we'll just open this up for questions. By all means, put questions in the chat so you don't forget them, write them down. We want to have this be as useful as possible for you, but there's a lot of information. So make it easy on yourselves, ask the questions early or write them down so you don't forget. But at this stage, I am going to put myself on mute and I will turn it over to Sergeant Prado.
Thank you, Ethan. Really appreciate giving us this platform. I'm actually going to pass it to Eric. Eric, I'll have you start, and then Hope and I will chime in at the appropriate time.
Okay, yeah. Hi, everyone. I'm a crisis responder with the CARES team, Eric Kinderman. And just to let you know, CARES started a few years ago as the community feels like they needed a different response besides police or EMS for mental health emergencies. And so CARES came about after a grant was given to us, and then the city and the mayor found funding to make us a permanent program. And I'm embedded here at the fire department along with a paramedic, and we respond to 911 or non-emergency phone calls or contacts. And it's nice because we have, I have all this medical and mental health records I can look at. The paramedics can look at the medical side as well as the legal side. So we kind of know what we're going into sometimes. And then when we get there, we do our assessments. We're assessing any medical emergencies or crises, psych, of course, and risk. And then we come to our disposition or outcome intervention. And our goal is to divert from the hospital as much as possible. So often we'll do a safety response plan, or we could take someone to a care center that's more geared towards someone having a mental health crisis. And we have freedom and discretion for our dispositions. We could take people to shelters, to homes, other places like that. Sometimes we get to help out other law enforcement and EMS because they're kind of tasked with, they can only transport to the hospital or to jail or something as well, when we can actually just find a different disposition. And sometimes we do help take people to the hospital who do need to go voluntarily. And so we often, with a safety response plan, we'll be doing some helping them find resources or filling out applications. We call their primary, we call their case manager, their therapist, their family. We're trying to help with the stigma of mental health is another thing we're doing here at CARES, as there's a lot of that out there in the community, and we do a lot of teaching to the community as well. So yeah, things have been going pretty well for us. We're responding daily to crises or emergencies, and Yeah, I guess that's all I got for now, guys.
Cool. Yeah, thanks, Eric. So here's what I'll say, because I assume there's law enforcement in the room, probably law enforcement in jurisdictions that don't have an alternative response program like CARES. I took the liberty, Eric, I hope it's okay. I threw in a link to your guys' annual report in the chat box. I think that does a really nice job of providing that overview of what CARES is, a little bit of the history. But you all are operating 7 days a week now, which is super awesome. I guess I wanted to, for law enforcement specifically in the room, I kind of wanted to throw up what I would say started as a bit of a maybe a misconception that I had about CARES. I came into our mental health unit in summer of 2022, so just about 2 years ago now. I came in as supervisor of the 6 mental health officers we have within the department that are dedicated to this work. And then we have had Hope and Sarah and Mallory as our embedded crisis workers that whole time. I've gotten to know them really well, but I'll say it. When I came into the unit, I came off of night shift patrol, and I came off of a very recent history that was 2020, that around around the country, was a pretty difficult time for law enforcement, where we had things and conversations occurring within the community that were literally called defunding the police, right? This was a call from the community, and law enforcement, we were kind of in the crosshairs of that whole political movement. And initially the thought was, oh, so just as I'm joining this mental health unit, and now a couple years after 2020, this is coming to fruition. This is a well-resourced program, one that our mayor, that our council was behind, that involved the fire department and Journey Mental Health, and not the police department. I remember thinking, okay, so this can't be good for us, right? We were on the chopping block for 5-10% cuts, reductions going back to 2020. Statewide, we've been on a trend of fewer and fewer police officers within the state. Maybe that's a national trend. It certainly seemed like and sounded like it. So here comes in CARES, saying they're going to take this workload, but isn't that down the line just going to result in fewer resources to the police? I mean, this can't be good for us. So that was my initial reaction. And if anybody out there that resonates with them, that's my hope, right? Here's what I'll say is CARES has been amazing. They've been amazing partners. They are diverting calls from our police department in a meaningful and effective way. When I think about what all the feedback that I've gotten from officers that are still pounding the ground, working the streets 24/7, what they tell me is they really appreciate having CARES as a resource, not only because it helps us stay in service and engaged for those higher level calls, but also because the community appreciates it so much. We have people calling in on a regular basis who say, my family member's in crisis, and for one reason or another, they don't want to see police. Police are just going to escalate the situation further. Can we get CARES to come out instead of police? And sometimes the answer to that simple question is yes, they're available, and it fits criteria for them to come out. But sometimes it's not. And I have one example of, I guess, a time where we've been really collaborative with CARES. There's certainly more examples, but for time's sake, I'll start with the one example of where we've been collaborative with CARES. Nothing that we as police do is in a vacuum, and nothing that CARES does is in a vacuum where we can't pass off to each other, where we can't offer each other up as a service. So back in the fall of 22, there was a case involving an individual out in the community that both police and CARES responded out to. Initially, there was a family member who was calling in saying this person that I love was making suicidal statements, and he had previously walked in front of some cars. The subject was displaying as paranoid, did not want to engage with police. Police officers did the best they could to talk with the person, to get more information from the family member. The family member ultimately wasn't making themselves very available to police. But in, just to streamline it for you all, in Wisconsin, that was giving us criteria to at least put this person into protective custody and potentially to effect an emergency detention. We weren't quite at the emergency detention stage, but it was getting close to that threshold where we might be taking somebody's rights away temporarily to get them to a hospital. And ultimately, with CARES being there on scene, CARES was able to engage with the person, and they got a completely different receptiveness from that person. They were able to get the person to agree to come and sit in their vehicle. They're rolling around in unmarked in the sense that they're not law enforcement. There's no emergency light package. It's a minivan that is decorated with the CARES logos on it. But it's not like a confined cage situation where somebody feels like they're in custody. They got this person to agree to come and sit in the backseat of their car. They continued to talk to the person, and the person agreed to CARES to go to the hospital with them. So that sounds like a win. They had to drive about 3 miles to downtown Madison to get to the hospital. And the officer decided, I think based on a quick conversation with CARES, that they would still like to follow behind CARES vehicle just to make sure that they got to the hospital okay. Them knowing as police that, hey, if things don't turn out the way we want it to here, we may have in our back pocket the ability to just emergency detain them at the hospital. So officer was following behind the CARES vehicle. As it turned out, they were about 3 or 4 blocks from the local hospital, from their destination. And the officer writes in his report, he starts to see feet come out of the back window of the CARES vehicle. They're going at a slow speed. They might have almost been at a stop. And then all of a sudden, the officer reports seeing not only the feet, but now the legs and now the torso. And now that person is literally exiting the CARES vehicle from the back seat and starting to run down the median of the roadway. So officer who has some experience and has seen some things, probably never seen this, decides to put on their lights package, stop traffic, and then they ended up going down the street and recontacting the person, getting them into police custody, and then walking them across the street to the hospital, because by that point they were there. I think while that might have seemed like kind of a chaotic call, it for me signifies that CARES, when they're being collaborative with police, as police we're being collaborative with CARES, and we both keep our missions in mind and we play our roles, that we actually do come to the better disposition. We do make things safer for each other. So Eric, I don't know if you had anything you wanted to add to that. I know you weren't on that specific call, but we talked about that one, and I thought that was one example of that. If you had anything else you wanted to chime in on.
Yep. No, that was a really good story, and sorry I didn't have a chance to share any stories on my end, guys, but yeah, I'll just share a quick one, kind of a normal one we respond to is somebody feeling suicidal who just doesn't know where he's going to go, doesn't have a job, and we were able to, safety plan with him. I was able to link him to these resources to help him with rent for a little bit. I filled out that application with him right then and there. We called his doctor together. Also got his mom on the phone to check in with him later. And then we gave him other resources to call or contact if his suicidal thoughts got any worse, or he was thinking of harming himself. But the idea is that we're preventing that can from being kicked again, because if he would have went to the ER, his main stressor was his financial issues or housing, and he would have just been sent to another appointment or another appointment. And so, yeah, sorry about the connectivity, guys. Whenever the fire department, whenever we get a call, it gets wonky. So I'm sorry about that. But
That's okay, Eric. We appreciate you chiming in, and what better reason for the internet to be a little bit funky than there's a crisis call happening right now. So totally understand, and thank you all for the explanation, a little bit of just what CARES does, how they collaborate with MPD, and that link in the chat. I do encourage people to read up on CARES through their annual report, get some of the additional history that way. So I'm going to turn it over to Chris Richardson and Tandis to talk a little bit about Denver and the Denver Star program, how it got set up, what kind of calls they respond to, just a general overview of how this community response program functions in Denver. And then we're going to open it up to question and answers. So if you haven't been writing down your questions, grab a pen now, throw them in the chat. But without further ado, Chris, take it away.
Sure. Pleasure to be here. Yeah, I think the great and powerful Madison, we kind of are in the same concept as them. So in 2016, we started our co-response program, which was the pairing of a clinician with an officer, and started out very slowly, intentionally, thoughtful with our partners, with stakeholders. How do we help support people in crisis? Viewing it from a different lens than law enforcement is, but doing it in a collaborative way. And so we just hit our 8th year of having a co-response model. Since that initial 26, we are 3 individuals, and we've upgraded to 28 individuals that are riding across the city of Denver in all the precincts. We've added, I love working in this field because it's my favorite people to work with. The second police had all these resources and we were seeing positive interactions, decrease in use of force, officer involves, IA complaints, all of a sudden the fire department was like, well, when do we get clinicians as well? Like, they can't have something we don't have. So we started pairing our clinicians with fire, sheriff. We have sheriff and police. So sheriff got co-responders to help with evictions, with mental health certifications, court-based stuff. And then last year we kicked off something with the park rangers because they were seeing more and more uptick in mental health and behavioral health stuff that is happening within our park systems around the city and county of Denver. So proud to have 28 individuals that are engaging with different first responders, having the outcomes that are still pretty universal across our nation, which is that reduction in individuals with behavioral health needs in jail, instead accessing services. The city and county of Denver partners with WellPower, which is our local mental health provider, to provide the clinical assistance, but also that immediate access to those behavioral health contacts. And so very proud of the kind of work that we've done and what we've set up. And I echo everything Jared said, that it's just been kind of like that force multiplier. My favorite people are the officers in 2016 that cussed me out and said this is a stupid program, that now are the ones we invite to these things to actually talk about how it has changed their life and how they couldn't envision being without a partner like that. So I think that does attribute a lot to how culture shifts and how you have to show the benefit and show how it can be impactful. And then the first responder world kind of says, well, this is great. This helps us all out. So, and then during that lovely transition in 2020, we were just sitting in cars thinking to ourselves with our fellow coworkers, the officers, saying, why are you guys going to that? Like, that doesn't seem something police should go to. There's no safety issue. There's no legal issue. And they're just like shaking their head. They're just like, we've always gone to it. And so that's what sparked the idea of an alternative response program that really is meant to keep officers on duty going to those calls that are more high acuity, that do have that legal prowess, maybe safety concerns, but leaving really that low level stuff that comes across 911s on a more regular basis than not to our community-based programs. And that's where Tandis kind of takes over. And no one knows this yet because I hope she brags about it, but Tandis actually started the one in Aurora as well. So it's a neighboring city. So she's with Denver now. We tried to steal her then. She went to Aurora. She's back. They always come back. So.
Thank you. I was worried my mic wasn't going to work last minute because tech issues, right? So yeah, the STAR program, just as Chris mentioned, started as a pilot in 2020, and similar to what Eric shared, there's definitely a push in the community for alternative response programs here in Denver as well. And so the STAR program has a master's level mental health professional and a paramedic. The mental health professionals are from WellPower, and then Denver Health provides the paramedics and sometimes EMTs. And the crews are dispatched through the 911 system. The city of Denver actually categorizes STAR as a fourth type of response. So they kind of look at it, next to PD, fire, EMS, and then there's a category for STAR. So there are some specific ways that they look at dispatching appropriate calls for STAR. And really, those calls consist of anything that has some sort of a crisis component, right? And we always say that crisis is self-defined. So that could be something that is related to mental health or behavioral health related issues, substance use, homelessness, poverty, any of those things. And in late 2022, there was actually an addition to WellPower and Denver Health. And so just to kind of provide more resources, more wraparound services. There was a addition of the Servicios de la Raza, which provide our case management and kind of follow-up care. So really the goal is to, divert from unnecessary ED visits, really look at that least restrictive way of supporting people and getting them connected with most appropriate types of resources.
Excellent. Thanks so much, Candace, for the overview. And at this point, I am going to switch us back to gallery and say to folks once more, if you are willing and able to get on video, we do appreciate it. It helps with the conversational aspect of this kind of session. So at this point, it's open for questions. Anybody who has an inquiry for any of our presenters here today, feel free to use the raise hand function, take yourself off mute, or you can just drop your questions in the chat. From here until the end of the session, it is just conversation based. So feel free. I have a couple of questions that I've received via chat, but I am going to just pause for a second and see if any. All right, we already have Denise. Wonderful. What's your question?
Hey everybody, thank you so much for the presentation. This has been helpful. I had a question for both programs. If you guys have data around any changes in usage. I know like in Atlanta, Georgia, we have familiar faces, which is people that have been arrested repeatedly. So I was wondering if you have any data around like the drop in high utilization of emergency services or arrests that you guys have gotten from your programs.
So from Denver side, we do see a reduction in general from arrests, not necessarily targeting high utilization individuals, but definitely from the average that the normal behavioral health flag with an officer without a clinician has. So that's about 8% of calls end up with an arrest, and we're below 2%. So there's definitely a decrease when a clinical team is part of that. And for both our co-responder and our STAR team, the Urban Institute is doing a comprehensive 4-year study that allegedly, Candace, correct me if I'm wrong, allegedly is going to be out next year that kind of reports a little bit more on that.
Yeah, and for the care side too, I'm sorry, I don't know those numbers, but I know we often measure it, just how many times we avoided the hospital is the big one. And it is quite a bit. For every 10 calls we get, maybe 1 goes to the hospital.
Something to just speak towards in generalities with Madison is our program is learning how to capture the right data so that we can keep the right stakeholders wanting more of us. And so that is something that we are working on right now as a larger group with CARES and with MPD and with Journey Mental Health, is capturing those data points. We're finding that, yes, right, like we're seeing similar to Denver, less arrests, probably more diversion because of the CARES team. People are also probably being emergency detained and getting the mental health treatment before they're going to jail. And so that in itself is a larger community win, right? Because they're getting that mental health treatment, then they're being gone or going to jail already with that treatment, so less likely to reoffend, right? So we anecdotally are seeing all of that, but we're learning as a team how best to capture that. And if anyone has any good ideas, we would be glad also to take some pointers, because that is something we're realizing that we need to do better at.
Well, Hope, we're going to have a longer conversation because the CSG Justice Center does have some resources on data collection. We do have some resources. We actually have a really beautiful toolkit, which I will put in the chat for everybody, on expanding first response, which is our toolkit about how to start up a community response program. So we have some questions in the chat. We also have some hands raised. I am going to start with those who have their hands raised. Denise, I'm assuming there's no follow-up on your question because you brought your hand down. Thank you. So Heather, do you mind coming off of mute, introducing yourself?
Sure. Sorry, I don't have, my camera's not working well. But wondered what role, if any, peer recovery specialist, which is what they're called in Virginia, or whatever version y'all have in where you are, play in your co-response or your different programs.
For Denver, I think it's something we want to explore better and more usage. Anyone that's familiar with the peer coaching and peers recovery, there is still a little bit of a stigma, especially in certain areas of either first response or crisis work. And I think we're trying to break that a little bit. RMS, access to emergency systems also requires that people sometimes that have that lived experience that would be really beneficial may not be allowed access to certain things, which would prohibit them. So we're trying to figure out in Denver, at least, how do we break some of that? And right now, and Candace can speak a little bit to Servicio on that. We do have peers, but it's more of the crisis is done. We've come up with a plan. We hand it off to people that are going to do more follow-up to the connection tools around safety planning and what that might look like. And that's where peers are really impactful. But I still think there's a huge niche area that we can have peers on the front lines that would be really impactful. And I'm hoping, I think Candace and I would love to see in the next 2-3 years that to be more of a consistent thing, and kind of showing that we can get good people regardless of degree or education, but just have the right people for the right fit to respond to these individuals.
Yeah, I agree. And hopefully that is something that we can start to kind of integrate into the programs. I will say though, something that's unique to STAR, or at least I feel is unique because I haven't heard about it much in other places, is that we do have a community advisory committee that is quite involved in, we just want to make sure that there is a space where people with lived experience in the community do have a voice, and that we're taking that into account when we're looking at program evaluations and how to make things better.
Thank you.
Yeah, with the CARES team, we actually, one of my colleague who's not here today, he's a certified peer support specialist. And sometimes with our safety plans, we connect them to our crisis unit where there is other peer support specialists available. But it is really, that lived experience is so helpful because it's a team over here, of course, and he can actually, or the peer specialist can kind of give us some more insight that we're not seeing, like knowing that sometimes people have to steer their own car in terms of recovery, and you can't really force these things on people where it's so easy to in this position, like, hey, here's our opportunity to help this person, and it's just really awesome to have someone with that kind of experience here.
Great, thank you so much.
And Heather, I do just want to draw your attention to the chat. Brad and Kyle have both put in comments about their team's use of peer response. And so far, very, very complimentary comments saying that it's invaluable. I can also tell you that one of our other learning sites, it isn't a community response program, but it is a multidisciplinary response program. In Bexar County, Texas, they have peers do follow-up. So if you're seen by a co-response unit the next day when follow-up happens, one of the people doing the follow-up will be a peer responder. So slightly different because it's co-response, not community response, but still in the same vein. And I would definitely encourage you to, maybe private message Brad and Kyle to just talk a little bit more about their use of peers. It seems like they've had some good experiences that they could share.
Great, thank you.
All right. Folks, this is a great group. We got questions lined up here. Carrie, do you mind introducing yourself and letting us know what you're looking to learn about?
Hi, thank you. Yes, Carrie, with the Carter Center. I'm a colleague of Denise, who was on earlier.
Oh, great.
Sorry, not on video. I'm working from home today and always reserve the right to not be on video when I'm on work from home mode. My question for CARES and STAR is really related to how they tie into call systems. I know that there was mention of 911 and certain calls getting rerouted to CARES or STAR. But I know, at least here in Atlanta, the 911 system is overburdened. And so we have the City of Atlanta non-emergency service lines 311 through which some of the calls for PAT are routed, in addition to some of the calls to 911. But I think the idea is to try to get more of the calls going into 311 versus 911, and then also link into 988. So I'm just curious how CARES and STAR, if they do use other non-emergency lines, how that works, and or if they have plans to do so, what that might look like.
So for STAR, we do utilize 988. There's a connection between 911 and 988 in Denver. And so there are some specific calls. And if they meet that criteria, then we do transfer those calls to 988. And then, there's the non-emergency line, as well as STAR actually has its own specific phone number as well that people can get in contact with. Both of those still go through the 911 dispatch system in Denver. And so, I think obviously emergency services, I think there's always a burden, but there is specific calls that we are trying to send over to 988 and kind of trying to balance that a little bit.
And
Yeah. Oh, go ahead.
Go
Yeah.
ahead, Eric. You sure? Okay. Yeah, basically all of the CARES calls for service come in through our 911 center still. In fact, our 911 center does a really solid job of triaging and figuring out what the best resource to send to a scene is. And so that could be police alone, it could be fire or EMS alone, or it could be CARES, or it could be CARES with law enforcement, it could be CARES with fire. So like any variation of those three really, but they're gonna, and it speaks a little bit to the territorial question as well. I think because it goes through our 911 center and because they have their set established protocols on who to send for what purpose, it's all very clear. Now, I think it was always built with the ability to adjust and constantly assess and adjust those protocols over time. And I think we've kind of learned over the last couple of years from just unique situations that arise, how to better address it. But part of that is we have a couple times a week, we have meetings with CARES, with MPD, with Journey, with 911 Center all together, where we can discuss these cases and these issues as they arise. And so, just definitely fill it in, Eric, if I miss some here. But the main things that police are going to be sent to and is not going to be a CARES initial dispatch are going to be when there's a potential bodily injury or death to a person when there's such an imminent threat or risk of harm that the more protective way to address it is to be with law enforcement with all of our tools. There's also going to be, if there's any weapons information, now access to weapon is something that we've kind of learned over time can mean different things. And so our dispatchers are learning how to wade into those waters better and get a better picture of what does access to a weapon mean. Does it mean that they have it in a safe, locked in a different room than where they are, and they can talk this person out of the residence? Then that is something that CARES can still go to, versus I have a knife in hand and this is going to be a police day. And then also if there's some allegation of criminal activity that needs to be investigated, that's going to be more appropriate police going. Now, what I've seen in practice done is that police will initially go to a call and they will stabilize whatever this criminal or imminent risk threat issue was. And then they ask over the radio for CARES, and CARES can come out and still assist on that call. We do a warm passes off all the time from police to CARES because we are able to stabilize that initially and then refer to the community resource there. Eric, I don't know if you have more to fill in on that.
No, that's exactly right. Yep.
And before we move on, Chief Brinkley, I know you messaged me a question very similar to that, so I don't want to skip the line. Adam, don't be mad at me, but Chief Brinkley, did that answer your question? Because you were similarly asking about triaging the call and dispatching.
Yeah, I appreciate it. And Sergeant Pardo, if I could ask one follow-up question, do you know what training specifically you guys provided to dispatch, kind of in that to help them do that over the phone triage of what you're dealing with?
Okay. Hope might be able to speak to this a little better than I can because I was coming onto the unit just as CARES was getting launched. So I think some of these preliminary discussions happened by way of work group.
Yeah, so oddly enough, the sergeant of our mental health unit went to be the supervisor at the 911 dispatch center. So there was like a very easy, direct, clear line of communication between all of the teams. And that led to multiple work groups where they would send out various scenarios and everyone individually would fill out where they felt the most appropriate response. Like, would it be CARES? Would it be police? Would it be both? And then they would come together, and then these work groups for quite a while, I know some of the mental health officers sat in on those work groups. They would really pick apart and tease apart. And then again, by luck of the draw, right, Sergeant Shimko went over to the 911 center. And so then she was able to like really work on that training with her team. So yeah, we kind of got lucky with that transition, actually.
I think what we recognized is like we each had within our respective agencies, we had some area of expertise. And so what was crucial was that we had all the important stakeholders in the room to work through those what ifs, not even a what if, but a when then type thinking of we expect this to happen. So let's have a plan for it. And having a plan that adjusts over time is, you know, being flexible as a decision maker is important. And so we've certainly adjusted as we've gone along as well.
Thanks. And is your dispatch part of Madison PD, or is it dispatch for multiple agencies?
It's a county-wide effort. Our 911 center is county run and dispatches for over 20 agencies, police and fire.
All right. Thank you. I appreciate it. Thanks for
You
letting
bet.
me get over there, Ethan.
No problem, Chief. Glad we were able to answer your question. And moving on to Adam.
Hi, thank you all for all your incredible work and insight. I got a couple questions. So, but people have asked a few of them. How big are these programs? I know care centers were mentioned. Like, was the grant pretty large? How did it start? Did it start small and you expand hours? Like, did you start 7 days a week? Are you going 24 hours? Interested in kind of some of the founding, you know, from that community push. How did it, how did it scale?
I think for all of Denver's programs, we started out pretty thoughtful and intentional. So it was dedicated district and dedicated hours. I think it was Monday through Friday, 10 to 5, to show concept and proof that there is something that exists here. And then as we saw stuff that kept happening that was working and said this needs to expand, then it was, okay, how do we expand? Is it citywide first, or is it more time-wise first? And then being able to build out from that, and then naturally beg, borrowing, and stealing money along the way to expand the need for not only vans, but personnel and all that stuff.
And has some of that funding like as sustainable? Like, are you guys also measuring kind of the financial impacts of your programs to the taxpayer benefit, things like that? Are those some of the measures?
It will be one of the measures for sure. So Denver is very unique, and I hate talking about this because it just feels like we're like so glittery and awesome with all the stuff we do. But we passed a tax initiative when all these programs were kind of kicking off called Caring for Denver, that basically funds through a tax initiative, quarter on every $100 spent goes to behavioral health alternative to jail programs. And so our co-responder team and our STAR team are primarily funded through that. And it written in the ordinance forever. So we do have that ability. Now we do get capped after a certain amount because we can only encourage Denver to spend a certain amount of money, but it does give us the sustainability and the ask to continue to build on that. And then the ever tricky one is, instead of using jail beds as we're diverting people out of jail beds, or we're diverting people out of ER, that cost still hits someone else somewhere else. Like, we just think that's more appropriate cost hitting, like Medicaid when someone's in treatment, or if it is an ER instead of a bed. Like, it's figuring out, and that's where Urban Institute's going to come in and kind of say, here's the cost shifting that takes place. It might not be savings, but it's more appropriate usage of money in the more appropriate trauma-informed access to care kind of way.
And then sort of maybe my last question is maybe for the police.
Well, hey, Adam, I could add on to that if you don't mind. For the CARES, though, that before they actually looked at the data of all the 911 calls in the city, and before we started, and determined we just started small, 5 days a week, but we were during the peak hours of mental health related calls, and that was from 10 to 8. And then we expanded into now we have 3 teams, and we're covering 16 hours of the day from 8 to 10, which is still like the peak, according to data, the peak times for our type of calls.
Not overnights.
We're not overnights yet. We are weekends now, though, and holidays.
And I'll offer up one thought on this as well. So in my work with federal grantees around the country, I do a lot of work with co-response. So not necessarily community response, but oftentimes co-response asks themselves the same questions. If we're going to start up this program, how are we going to start small and scale up and be efficient in how we're utilizing this new resource? So oftentimes people will do what Eric said, which is an analysis of the calls that you've had in the past year, filtering out for the call type, right? So you identify a couple of call codes that are most likely to be mental health related, and then you look at the hours that they're coming in. What I've also seen be really effective for co-responder teams is they will put a flag in their CAD system, not just for when the mental health person came out on a call with them, so co-response utilized, or in this case, community response utilized. They'll also create a flag in the CAD system for could have been utilized but not available. So like co-response desired but not available for those overnight shifts, because, okay, if we're going to start with 5 days, I think you said 10 to 8 or maybe 8 to 8, Eric, sorry. If those are what you're starting with, well, it still helps to track outside of those hours, what is the call volume? Because now as your law enforcement officers who are going out on calls understand, well, I would have normally called in cares on this one. And as they build up that muscle memory, oh, I would have called cares, they're better able to identify, well, I would have called cares, but I can't because they're not working. And then you end up with this really beautiful piece of data that says, these are all the times that you would have utilized this new team. They just weren't operational. They weren't working those hours. And so then you can get real-time data of this is how often we utilized, and this is how much we would have utilized if we had expanded to 7 days, if we had expanded to overnight, and you can kind of adjust as necessary from there.
Thank you. And then for both programs, but the officers in the room, I know somebody spoke about sort of that fear when the program, is this going to cut into our budgets, and the fear of sort of this push from the community. And is there ways that CARES or STAR were integrated that you would have done differently? Like, how were police engaged ahead of the program coming online? And like, were they stakeholders that were at the tables, in some of these work groups and things like that? Because we're here in Buffalo, New York, and major racial disparities, some calls for police alternatives for that reason, and some for mental health purposes, and kind of a combo. So but we have a co-response model, and so trying to, I want to know, how was it sold to the people who are already doing crisis response?
Yeah, I think I can, that's a great question. I think I can speak to that briefly. And Hope, I know you mentioned that the work groups early on involved our dedicated mental health officers. So, I mean, that's a subsection of our department of commissioned officers that are dedicated to mental health response. But I think their perspective was nice and nuanced, having come from crisis response background, but also acknowledging, hey, some of these calls don't need us as police in the room. Some of these crises that don't involve an imminent risk of harm are something that could be stabilized and brought to disposition without law enforcement entirely. I think we were hearing it from the community well before we had the solution of how to divert calls away from police. But now that we have it, I think it's a very easy sell. And I think the approach is, talking to law enforcement to speak in our language. It's, would you rather have officers available for the big one, for the calls in our community that involve, maybe it's 1% of the workload, but the very serious violent crimes that are going to take up a lot of your resources? Is it possible that by having somebody else respond out to these calls and taking them off of your collective plates of workload, that you're more available to go to the higher level calls? I think that's the easy sell, is approaching it that way. It's the same reason why we're going to where we've been going to third-party transports, because it's authorized in our state law now, where we can pass off some of our emergency detention transports to a third party. We budget money for that now, and it allows our officers to stay in community and available for the bigger calls now.
That is really interesting. And I'm just going to keep you on the topic for a second, because we got a couple of questions in the chat that are similar to this. So one of them is directed to Hope. So the question was, how might we get some of these stakeholder groups kind of started up if local leaders are not particularly interested in this kind of response, right? So it ties into the winning people over conversation, but not even necessarily police officers, more maybe electeds or community members. How were you able to identify some of the folks to sit in those initial meetings and say, all right, let's figure this out. Let's really tease out the differences and when we're going to use CARES? Is that something you could speak to, Hope?
Yeah, you guys are probably watching me make a funny face just because I'm like, oh, that's a really good question, and I haven't like really thought it out in that way. But we are kind of experiencing something similar to that in Madison right now, and just like our crisis continuum programs are being reevaluated, and they're figuring out if we're using the most efficient tools and resources, et cetera, et cetera. So it's funny that you asked this question, because we're all right now also thinking to ourselves, how do we engage those people? And for me specifically, I've been working in Madison in mental health for 12, 15 years. And I also teach in Madison at the college. And so I've just been pulling at the people I know that support the work that we do. So I teach human services, and I know the criminal justice program wants me to start doing mental health with them. That's a huge asset to what we do, because they like that we have a co-responder team here in the city. I'm reaching out to a lot of the agencies that we work with, more specifically CARES than necessarily say myself and the officers, but like our daytime resource shelters, our overnight shelters, our local emergency rooms, you know, like who are we really working with the most? And we already know we have their buy-in. And so it's a matter of getting us all together collectively, and then how to like send that message to leadership. Also, again, having Sergeant Prado and then my supervisor, Sarah Henriksen, it really comes down to having great leadership right here on the team, and knowing that I can go to Sergeant Prado and to Sarah and just be like, here are my concerns, here are my thoughts, what do you think? And they open that, you know, they welcome those thoughts. And I'm probably actually like sending way too many emails right now asking like what else we can do to like prove that we have a good thing going here that shouldn't go away. But that's like how we get it done, is like just kind of being a constant bother, I guess.
Community facing presentations. I mean,
Yeah.
we've been, for the last year and a half, we packaged a 60 to 75-minute presentation that our officers and crisis workers go out and do upon request. And part of that presentation is we think, okay, as law enforcement, what can we offer the community at large? Well, we'll tell them about de-escalation and how to have conversations with people that are upset. So that's kind of how it started, was as an idea of what can we offer to the community. But we're able to sell our unit to any audience that we get for that. And we tell them about our unit and about what we're doing to divert people away from jails and to hospitals when appropriate. And we're there to field questions of the complexities of our laws and how things interact, and how our services and CARES' services interact. And so that's, I guess, one small way.
I do just want to really quickly add that our team is really intentional in the work that we do, and we're very cohesive and we're very close. And I think that is a part of what makes our team so great and easy to have these community presentations, because I think they can see the relationships that we have with one another and the bonds that we have together. And you know, when I respond with CARES, like, I don't want to speak for Eric, but I see that between them and their paramedic that they're paired up with, like, you see that we're very cohesive. We're all on the same page. We constantly are communicating, but that's because we're very intentional about who we hire for these positions. And I think that speaks to retention and a whole host of other things, right, that you could go towards. But having a really good team to support one another, that's where it starts.
Awesome. And Jennifer, you've had your hand up for a while. Where are you from, and how are you coming at this conversation?
Yeah, so I apologize. I was driving, so that's why I was not on camera. But I have
Perfectly okay.
so I don't really have any questions other than I jump on these a lot of times, one, just to see if there's anything that I can learn across the country. But I'm from Albany, New York, and I oversee and run a 6-county mobile crisis. It is a community response. However, we also co-respond with law enforcement through some 911 diversion programs, and also other probation or not jail, but we say jail diversions, but it's folks that have been locked up and are just waiting to be released, that were normally being brought to the hospital since they didn't have somebody to evaluate if they ended up like on a suicide sit. So I just was hearing a lot of questions about peer response and data. So I just wanted to offer not today, because I know there's not a lot of time left, but I definitely think that it's always great to learn from each other, because there's a lot of different challenges. But we are county and state funded, but also back in 2019 started to be able to bill Medicaid, which has allowed us to expand our hours and services. We are not 24/7, but that's because the data has not shown really past 2 a.m. Most officers will tell you that anything past 2 a.m. really is not necessarily anything other than a police member or probably needing to go to the hospital. So that's why we have not expanded to 24/7, but the data is super, super important. And working closely and collaborating with law enforcement. I train at the State Police Academy and also our local academies, because that bond and that relationship is who your advocacy is. If you want mental health response or co-response, or your folks in your counties to buy in, and your data is super important. So anything that I could do to offer for what data we collect, and our response is a team response. So we respond with a mental health clinician, whether it be a social worker or a mental health counselor, with either a family advocate if it's a youth call, or a peer specialist with lived experience. Sometimes it's 2 clinicians, but our model is to respond with a peer. And then also we do follow up and referrals and all that. So I just wanted to put out there, I'm always looking for new ideas and ways to grow. So anything I could do to offer anybody, anything, I just wanted to offer that. But I'm always looking to see how we can challenge our programs or grow. And someday we will be sitting next to the 911 dispatchers. That's my dream. But so far I've only been able to get us built into 911 systems, where if they're able to transfer the call, they do, and then we respond on our own, or sometimes co-respond, or police just ask when the call comes in. We have our own flag on their systems as well. Like somebody mentioned their CAD systems and stuff. So we're like a Northern Rivers response. So if 911 decides that we go, so we have a lot of things going on. So I just wanted to put that out there, and I would love to have opportunities if the folks that are doing this presentation could somehow get their information, so that I can just learn a little bit more about what they're doing that we might be able to implement outside of what I've learned and listened to today. So I can put my email in the chat if that's okay with you. But I just wanted I was hearing a lot of things that we're doing, but also things that I would love to learn from. So.
Yeah, absolutely. And you are more than welcome to put your email in the chat if folks want to reach out. But I will also, that was a really great segue for me to plug the program again. So all the folks who are on our presentation panel today are attached to one of our law enforcement mental health learning sites. I've just put the learning site program link in the chat for everyone. And if you can't find it, you can just search law enforcement mental health learning sites. All of the contact information for Sergeant Prado, for Chris Richardson, is on that website. Since this is community response, not necessarily law enforcement led, we don't have Eric and Candace's and Hope's information on those websites, but we do have the law enforcement partners email up on there. I know Chris and Jared love getting emails from our folks around the country. It sounds kind of sarcastic when I say it, but actually I mean that literally, because it's fun, like teaching people and sharing with people from around the country and getting to say, hey, look, we have this really cool thing. You should have it too. So reach out to Chris, reach out to Jared, and their contact information is on that website. You can also learn from one of our 13 other web learning sites, and maybe even go back and watch some of the Ask the Experts that they did, because we've done a couple of these now. So lots of good information out there for you. And Adam, before I get to your hand, there were a couple of questions in the chat I just wanted to get through so people know I'm not ignoring them. So one of the questions that got raised was if anyone has used community response in a more rural area. Now for Denver, I actually don't know Denver as well as I I like to think I do. But I don't believe that there are any particularly like rural areas. The city limits don't extend that far, do they, Chris? Okay.
Yeah, no, we're pretty urban. There is a new one that started up in Salida, which is a huge county, but pretty rural community in the western slope of Denver. But we don't have much info yet on their program, but very rural.
Okay, so Salida is something to keep an eye out for. And in Dane County, because CARES covers the whole county, right? Eric, are there any particularly rural communities that CARES serves?
Currently, we're just the city, but other municipalities outside of the city are handing in applications for our services. The county's offering grants to help some of the surrounding areas with funding. So we're growing, and it's just a different way of it.
Mhm. Yeah, I don't know a ton of community response that are happening in like highly rural areas. What I will tell you is that one of our other law enforcement mental health learning sites, Yavapai County, Arizona, is enormous. I think by land area, like by square mile, it's the same size as like Rhode Island. Like it's as big as a state basically, and it's bisected by a mountain range. So they don't have community response, but they have mobile response, which is very similar. It's just run through the mental health provider, and there's not a paramedic that goes out along with them. But they do have mobile response in Yavapai County, which is incredibly rural. And one of the reasons that they are one of our learning sites is because they were able to set up a system where mobile crisis is able to respond in 30 minutes or less, even in such an enormous county and covering so much land area. So that's not exactly the same, but it is similar. I would encourage you to reach out to them. Their contact information is right on the website, just like everybody else's. And let me see, what other questions do we get? Our other questions are about data. I'm gonna see if Adam and Trish have anything data related before we circle back to that. So Adam, do you have a question for us?
Not data related. I was wondering, I know it's been mentioned a couple times, but the care centers, like, is that a part of the care team? Like, are there brick and mortars for both cares and stars that you guys are diverting people to?
I think care center may have been like a catch-all term for like a crisis response center that somebody may have said.
That was me. Sorry, those were actually established before CARES. It's an alternative to the hospital for any mental health emergency. So your suicidal people or somebody who's just really sick and need to get back on meds or stabilized. It's just a really good program that they can go to instead of the hospital for those kind of services.
Are you guys are there peer respites as well in your states?
There is peer respite homes. Yep. Those are kind of harder to get into. Typically, somebody needs a lot of providers and other things in place first before they could use something like that.
Thank you.
And I see some activity in the chat with Nicholas about like a tablet-based response. And I'm just going to once again plug our learning site program. I think we actually might have Keisha on the line right now. But in Harris County, Texas, and Houston, where Houston is located in Harris County, they have this program called CORE, Clinician Operated Remote Evaluation. Clinician officer remote evaluation, and you can learn a ton about how they got that set up, because I know there's been discussion in the chat about the use of tablets to do evaluations in really rural areas. The Harris Center for Mental Health and IDD has done a ton of work in Harris County on that subject. So if you're interested at all, I would encourage you to check out that website. Reach out to Keisha Lorio. She is phenomenal. And Jared just put some more information in the chat as well. So I'll be quiet and I will turn it over to Trish.
So I'm the one that brought up the rural question because I always tease everybody that I'm almost a Canadian. I'm like 10 miles from the Canadian border. And North Dakota is rural in and of itself, but the two counties that I work in are crazy small. Or the counties are big, but they have these crazy small towns. And it's very different from a girl who moved from a major city up here. And so I know that a lot of the calls that our sheriff's departments and people work with are in some way mental health related, substance abuse, like that kind of stuff. And I see them get very frustrated and quit wanting to go out and help people. So I am open to any ideas people have, any programs that are out there that might work, that some way that I can try to help people in these counties, because there's not a lot of help, and the closest major cities like an hour and a half away.
And quick follow-up question, Trish, are you a clinician or law enforcement?
So I am neither. I am the domestic violence advocate.
Okay.
But I have my degrees in social work, and I went to the police academy before I got off on this tangent. So I have at least some of that background in both areas.
Yeah, I guess the major thing that comes to mind for me is like we have a local crisis call center, completely separate from our 911 center. It's one staffed by Journey crisis workers, and that works really well for our community. But when I think of more rural areas of Wisconsin, I also think of like, what's the 988 connection? And is that something that officers are feeling comfortable referring people to? Because you're guaranteed that call center, and it's a simple messaging to people anywhere in the nation to say, hey, this is a resource for you. This is somebody who can literally talk to you for 30, 40, 2 hours about your issue. And I just wonder, it's something that we've tried to message more internally with our officers, that they know it's a resource. I know, Hope, that when you work the call center here, that there's definitely people that you refer to 988 as well.
Mm-hmm. Yeah.
So I do know that it's something that our public health and different people put out. I mean, I have the little magnets and stuff, and I have that information to give like somebody that came into my office. But you're talking about community that I swear I stepped 30 years back in time when I moved here. There's a lot of good old boys club. That doesn't happen here. So I find a lot of times that officers maybe are uncomfortable, or they just don't realize how much of a crisis it really is. And it scares me. I mean, the kids here have mental health issues. I see them when I go into the schools to teach. And so I'm just trying to find a way to make a community that my grandkids are starting to grow up in safer.
So I think how to kind of message to the law enforcement community is a challenge that a lot of us on this call have had, and really trying to drive home the importance of mental health while destigmatizing the entire conversation, because no one, especially in some of these communities where folks are resistant to acknowledging mental health, no one wants to be the weak one. Nobody wants to be the one with the problem. And so we build up our defenses. I think that in my experience, one of the ways to broach this subject is to find a champion in that community, somebody who has a autistic child or a niece or nephew who has battled depression, someone who has a personal connection that then you can use as kind of your entry point, right? and collaborate with them on, okay, I know you know personally the importance of this conversation. Can you help me start the larger conversation with others? Now, is that something that's very easy to do? Well, kind of depends, because it requires that you know some of the folks in the community really well enough to know that their family members or their friends have had a mental health challenge or a struggle or a diagnosis. Another thing that I'll say, and I'm hoping that our panel here will back me up a little bit with other thoughts that they have on how to go about these conversations. But I think another thing to do when you are trying to really get across the importance of mental health service provision context is to start with law enforcement and to say to them, hey, if mental health is important for you, it's important for other people. And that can look a couple of different ways, but it can even start with something like, do you have trouble sleeping ever? Because a lot of people don't really want to turn that looking glass inwards and admit, well, I might have some PTSD. I might have an issue with sleeping, or I might have an issue that I'm not really wanting to address, but I can acknowledge that, okay, if this is something that disrupts my everyday life, well, then if that is more intense for other people, then I can build a little bit of empathy that way. We ran a community of practice last year about delivering mental health support to law enforcement officers. And this was a lot of how those conversations started, which is just, let's dig a little bit deeper than, hey, how you doing today? If I ask a question that's a little bit more in depth, how did you sleep, or how are you feeling? Have you thought about that call we took the other day since that call? You can get people to open up and engage with their own mental health, not necessarily in like a big scary way, let's all do talk therapy together, but hey, if you can acknowledge that this is something that you're facing and that you're having a challenge with, that you might need some peer support. A lot of departments have a peer support program. If you've ever utilized peer support, well, then you understand that mental health is physical health. Your brain is an organ, you know? People want to try to separate the two, like our insurance separates dental from the rest of it, but guess what? It's all part of the same body. And mental health is physical health. And so we trying to grab somebody's attention with an issue that they may be facing in order to leverage that empathy for others would be something that I would consider in those person-to-person conversations. But if there are any other thoughts about how to generate these conversations, get across to law enforcement folks that this is not something that can be ignored, it doesn't exist, it does necessitate our attention, I'd be happy to hear from everybody else.
Yeah, hey Trish, I'd just like to share that about the rural areas, that it's definitely an issue here in Wisconsin. Farmers are really a big thing here, of course, and farmers' suicide rates are really high, and it's hard to support these people because they work all the time, right? And if they miss a day, they could jeopardize everything. And with Dane County or Madison, sometimes we're able to connect them to our crisis center that's for the whole county, and have a crisis worker kind of check in with them, or they can call at any time. And sometimes they just need to talk before they get back on the tractor to finish the field, you know, and because they are there's that stigma, they don't want the attention, but they are really struggling. So I just wanted to share about that and how Wisconsin tries to help them.
Thank you guys so much for these ideas. I really appreciate it. And it at least gives me kind of an idea of how to approach our law enforcement and people within our community to try to eventually bring something like this to them so that I can make a difference here. So I really appreciate the help. Thank you.
I was muted. Thanks for asking the question, Trish. We appreciate it. And I will also just kind of remind you, and maybe even when the recording is on our website. You may even want to steer people to just that minute or two that Sergeant Prado was discussing his own experience and his resistance to these ideas and the team before experiencing, oh, wait, this makes my life way easier. I actually love having CARES around. I think some people in the chat, Peter said that, you know, starting with a discussion of data and asking them, hey, chief, how long do you normally have to have one of your officers out of service waiting in a hospital? We could do something different here and you could get that person back in service. Sergeant Prado again said something I found really pertinent, which is chances are there's 1 or 2% of your total calls are all hands on deck. This is a life or death emergency. This is so serious. We need everybody to respond. And you want your officers free for that. So if you can tie the ability of your officers to respond to more serious, dangerous calls with getting some of these lower level calls of suicide, a welfare check, or suicidality, like somebody speaking about it, not somebody actively pursuing suicide, then you can reserve some of those patrol officers to get back in service quicker. So I think there's a two-pronged approach there, to be sure, which is one, you know, the empathy and trying to connect with a person about this is real and this is important. And the other is bottom line. It'll help your agency be more effective. It'll help your officers not have to respond to these kinds of calls. Somebody mentioned earlier, familiar faces, right? A lot of calls for service are generated by a very small portion of people. If you can demonstrate that, you know, Ethan Aronson, who normally calls 911 50 times a month, only called, you know, 30 times, 20 times, or was able to be responded to by a different team, you can more easily convince your chief or your other law enforcement partners, hey, this is worthwhile. It's going to keep us all in service. Okay, so we have a couple of minutes left and a couple of questions. One that I really wanted to get to was, we had someone ask about the educational and experiential qualifications for community responders. So what makes a good ERIC? What makes a good community responder? How do you decide on that? So Madison and Denver, we'd love to hear, what are the qualifications that you're looking for a community responder?
Yeah, I'll go first. I think it's really important that the responder has a knowledge of the resources in the community, knowledge of recovery and how different ways people recover, know about the stigmas, and open to teaching the community about psychoeducating and educating the community. I have experience. I used to be a mental health case manager. I used to work with the crisis stabilization centers as well. Worked at a detox facility, worked for a health and wellness family medicine clinic, and I was also an EMT. So I just kind of was luckily been in crisis most of my career and found this position and just kind of got luckily found one of the best jobs I've ever had, actually. So.
So all of our mental health professionals have a master's degree. Most of them are licensed. The co-responder clinicians are all licensed. And then most of the STAR clinicians are also licensed, and then the paramedics obviously are certified in their, I don't know exactly what it's called, right? But they have their paramedic education. And then I agree with Eric. I think having a general understanding of the resources that are available is obviously really helpful. Thankfully, we do have that case management services through Servicios that kind of helps with that. But I think overall, just having, which these are things that we train on, right? But understanding risk assessments and safety planning, means restriction, all of that good stuff kind of goes into the training process. But as far as the qualifications, we're just looking for a master's in a mental health related field, and hopefully some clinical licensure as far as the mental health side, and then the paramedics, and we also do take EMTs.
They're like a new.
Sure, sure.
I just want to add, so in Wisconsin, we're a little different in the sense of like how we can emergency detain somebody. We have to have a mental health clinician and a law enforcement officer both sign off on them. And so something that's really unique about the CARES program is because it's so heavily based on an alternative response, the CARES team does not assess for those emergency detentions. Their true mission is to divert from law enforcement, best disposition, least restrictive necessary. And so Eric and the team over there, like, it's just a little different in qualifications. Now, as far as like Mallory and I, who's my peer here in the city with law enforcement, both of us are licensed. And we have a little bit more autonomy in that way, but a lot of that has to do with because we are actually assessing people for involuntary holds. And so having that clinical background and expertise is really important. And all the crisis workers on the CARES team, as Eric said, they actually, most of them started on the crisis unit, so they have that training. It's just a matter of being able to have that autonomy out in the field and not necessarily needing a supervisor and things like that. But also something that I really want to hit home with some of the folks that don't already have a program established. We are Medicaid reimbursable, and based on our qualification is how much we get reimbursed. And so something to keep in mind. I totally agree that peer support should be a part of the continuum. Not everyone needs to have a license and things like that. But if you are kind of like us and a third party contracted with the county as regards to like crisis billing, it is something to consider who you hire and what qualifications they have, because the Medicaid reimbursement rate is different. And so just to put that out there for new teams.
Okay, folks, we have just about 3 minutes left. So the only questions that I have remaining in the chat are about data. So I'm just gonna ask for a quick, bite-sized piece from our presenters about any return on investment data that you have, or just to expand on an earlier comment about, well, you want to collect data, but you also want to collect the right data. So if there's anything that you can expand on there as far as what you would consider the right data, or anything that's been collected around return on investment, we would certainly love to hear it.
Actually, to speak to that, Denver, you guys said that you just had a soon to be 4-year study that's going to highlight a lot of those data points. And so honestly, from our perspective, we're really interested to know on like what are some of those data points that are being collected.
Sure. Candace, can you speak to that? I think we lost Chris.
A little bit. I mean, we're hoping for it to be out next year. I think it's a little bit difficult, I will admit, when it comes to data, just because, if I'm being completely honest, because there are so many different entities that are involved, right? So the city and county of Denver, which includes 911, as well as the public health department, right? And then Well Power and Denver Health, and then Servicios, I think everybody sort of does their own data collection. And so I think Hope had mentioned this, you mentioned this earlier about kind of it's a learning process, right? Kind of figuring out the things that are helpful and the things that we're looking for. And so, yeah, I'm also excited to see some of those numbers because I think as of now, when we look at the data, we have a general idea of what's going on, but they're sort of in all these different pieces. So I'm excited to see kind of this overall report. And once it's out, would be happy to share. So
Absolutely. And I'll just comment for folks, one thing that's really challenging about co-response and community response when it comes to data collection is that it is nearly impossible to prove a negative. So it is really challenging sometimes to demonstrate return on investment or cost savings because there's not a diversion from jail is a little bit of a flexible term, right? What might be a diversion for one person might not be a diversion for another, depending on the officer on scene, depending on the clinician on scene, depending on how that person is presenting, depending on a lot of things. And so to then try to assess how many dollars were saved by this person not going to jail, it can get really hard because you need an incredibly specific definition of what qualifies as a diversion from the ED, from the jail system, so that you can say with certainty across shifts, across personnel, across everything, well, I would have taken this person to jail. There is a standard by which I would have brought this person to jail, but I'm exercising my kind of street level, what's the word I'm looking for? There's a research paper called Street Level Bureaucracy that I was thinking about in my head, but it's not that. It's your discretion is the word. So you're using your discretion on scene to say, okay, I'm not going to bring this person in. And so that does count as a diversion, but that's a really hard to define process. So I just want to put it out there that if anybody is struggling to define and to quantify return on investment, don't feel bad. It's a really challenging thing to quantify, especially when we're looking at proving negatives. How many people do we stop from going to jail? How many people do we stop from going to the emergency department? And then out of that, what was the cost of the ambulance and what was the cost of the jail bed and all of those kinds of things? It can be complicated. So I would encourage folks to, before you go to return on investment, first just evaluate the fidelity of our program. Are we doing what we said we would do? And quantify your program. Are we meeting the need of our community? With that, we're a couple minutes over, so I really appreciate everybody being here today. I want to give a big, big, big thank you to all of our presenters from Madison and from Denver. We really appreciate you sharing your expertise. Everyone, the recording of this event will be up on our website soon. Please do keep an eye out. We've got 2 more of these for the year. But I appreciate everyone taking the time to be here today. What a great discussion we had. So thank you all. Have a wonderful day, and I will see you all soon. Keep up the good work, folks.